There's a nice there's a nice pamphlet that's put together for physicians by one of the companies that supports PA. But just to go through it a little bit with you, so prostate, benign prostatic hypertrophy, or BPH, as you know, is really the thing that we're all going to suffer from at some point in our lives as we get older. It does occur in men that are over the age of 50, definitely people that are smokers, have other comorbidities such as hypertension, diabetes. We see it in certain ethnicities, so the African-American population and the Hispanic population are really two big groups that are affected more than others. And then anyone that has a family history of prostate problems are going to be people that are also going to be affected from it. So I've got that in my family. I'm sure at some point I'm going to be dealing with it.
That was my big question, was those risk factors other than aging and being a man, of course. So comorbidities is definitely are potential risk factors such as high blood pressure.
Yeah. So it's going to affect, really by the time we're all 70 years or so of age, it's affecting about 80% of the men. So we see it in about 20% of patients that are 40 to 79 years of age. Certainly when we get to the 70 to 80 age group, that's when we're going to start seeing it much, much more frequently. So the majority of patients, when they get BPH, it's treated first off with a medication that is an alpha blocker. And what that does is that affects the smooth muscle cells within the urethra as it passes through the prostate. So it's going to relax some of those smooth muscle cells, allows you to urinate a little bit easier. That usually works pretty well in the beginning, probably for several years. As you start moving into about 5 or 10 years from the onset of symptoms, you start getting into other types of medications. Some of the medications in particular are hormone blockers. And with those medications, men have a lot of side effects. When you start blocking hormones, you start having problems with impotence and gynecomastia, which means, you start to get a little bit of breast development and all that sort of stuff. So nobody's really crazy about using that type of medication.
No.
Once you've exhausted the medication options, or once you're tired of the side effects, the next thing is going to move to more minimally invasive treatments. What the urologists do are procedures to remove a portion of the prostate by going up through the urethra. Okay, so patients that have had a TURP, I'm sure you've heard about that in the past. A TURP is a method for them to access the urethra. They put a device in that cuts the inside of the urethra and scoops out portions of the prostate that are blocking the urine flow. That's still pretty much the gold standard as far as doing treatments for patients.
Really, and that's is it a outpatient surgery? But it's minimally invasive, correct? But is it outpatient, or is it how complicated?
So for a TURP, it's not. It's considered minimally invasive, but it's still a fairly invasive procedure.
Okay.
I don't know if the patients actually go home the same day. I think most of them stay in the hospital at least one day, maybe even 2 days after a TURP.
And side effects could be like within, potential side effects.
Yeah, right. So those are the side effects. So impotence is definitely a potential for a side effect associated with having a TURP, because they can damage the nerves if they scoop out large portions of the prostate from the inside.
Right.
The incontinence is another issue. So after, if they scoop out too much of the prostate, then you can result in incontinence, and that's not a trivial thing that does happen in a fair amount of patients. Once that option is evaluated, there are other things now that the urologists are offering. There are some minimally invasive procedures. They use lasers to burn off some of the tissue. There's a procedure where they actually put some little sutures on the inside of the urethra, and it basically pushes open the prostate. Those procedures are collectively called MIST, M-I-S-T. So there's minimally invasive procedures. And those have some variable efficacy. So what we're talking about is prostate artery embolization. Prostate artery embolization is really an alternative to having any of those surgical options. We do it in patients that have had TURP and have failed for one reason or another because their prostate's too large or if they have other issues. But it's an alternative method to treat the prostate by going into the blood vessels and putting some little plugs, little particles into the blood vessels that block blood flow. Over time, that gets the prostate to shrink down, and the effects of that pressing on the urethra minimize, and the patients actually do quite well.
And it's basically non-invasive. It's basically injecting. It's basically an injection, is it not, into the artery?
Yeah. So we do have to access the artery in the groin, just like the patient's having a heart catheterization or any other type of procedure.
Right.
We put the catheter up through the blood vessels. We get to the blood vessels that are supplying blood flow to the pelvis, and then even smaller, the blood vessels that are directly supplying the prostate. So once we get a little catheter into those blood vessels, that's when we inject the particles and blocks the blood flow. We take the catheters out. We hold some pressure on the access blood vessel either in the groin, or sometimes we even do it through the wrist. And then the patient stays for about 6 hours or so after the procedure and goes home the same day.
Okay. Now, I read this is described as this solution that is injected as microscopic plastic beads. Is that beads?
Yeah.
Is that correct?
That's what they are. They're little, small acrylic beads. They range in size from about 100 to 300 microns. So very small spherical particles.
Okay. And how much solution do you inject, or is there a? Yeah,
it's going to depend on the size of the prostate. So for larger prostates, it's going to require more particles. For smaller prostates, it's going to obviously be fewer. But it's several million particles that end up lodging in the blood vessels.
And the procedure sounds like it's fairly quick, or is it like half an hour or less?
It really depends on the anatomy. So you can have variable anatomy. There may be one blood vessel from each side of the pelvis that's supplying the prostate. Sometimes there can be multiple blood vessels. Patients that have a lot of comorbidities that do have atherosclerotic disease or plaque in the arteries, it makes it more challenging because his blood vessels can be stenotic or sometimes even occluded completely.
Wow.
So sometimes it could take us a bit longer to get into the blood vessels depending on comorbidities.
Okay.
I'd say on average, the fastest that we do it is probably in about 45 minutes, and the longest can be up to about 4 hours or so.
Oh my. Okay.
Depending on the variability.
And during the 6 hours afterward, or for recovery, if you will, what do you look for, or what signs?
The reason that we have in the recovery for 6 hours is because we need to let that groin incision or that groin puncture heal up.
Okay.
Again, from the groin or from the wrist, depending on which method we decide to go.
So it's mostly the incision area and not other issues necessarily, or do you want?
Yeah. The puncture area is really what we call it, because it's not really it's not an incision. The things that we do are not surgical procedures, but minimally invasive procedures through small punctures. After the procedure, most patients go home the same day. Mm-hmm. Do quite well. Most patients will experience some problems that feel like it's a small urinary tract infection. Okay, right. So there can be some burning when the patient. There can be some discomfort in the pelvis. There can be frequency, which means that the patient needs to void several times throughout the day. Mm-hmm. That typically lasts for about 3 or 4 days after the procedure, and then that gets better pretty quickly after that. Patients start feeling significant improvement, I'd say, by about 2 weeks.
That includes the urinary issues and everything else, and any other symptoms that. So, how new is this procedure, PA? Is it relatively new, or
So it's been around for getting close to 10 years now. It was originally done in Portugal and in Brazil. That's where it kind of originated. So there's good long-term data looking at patients that have had prostate artery embolization from that standpoint. In the United States, we've probably been doing it for about 5 years.
Okay, great. So that's relatively, that's not that long considering in the scheme of things of medical procedures. That's fairly recent. And any idea percentage-wise? I know it's hard to say, but of men with BPH or enlarged prostate, how many would be a candidate for this? I mean, what percentage? I know it has to do with meds and but are you seeing an increasing number of men who can be candidates?
Yeah, we're definitely an increasing number, and the indications are definitely expanding. So for patients that fail medical management, any of those patients can come for prostate artery embolization, whether or not they've had any type of surgical intervention. We've also treated patients that have had surgery and have failed surgery.
Okay.
I would say that the vast majority of men, this is a viable option for them when they have significant symptoms. So significant symptoms, most patients have some mild symptoms that can be treated medically. Once they get to the point to where they have moderate to severe symptoms, those are the ones that are going to be best treated with these types of procedures.
Okay. So let's go to Mr. Muniz. What was his, condition once he came to you? What was his? Had he had surgery or just meds? Or tell me about him if you can.
So he was on medications, and he was having side effects from the medications. He was not happy with some of the sexual side effects for sure was part of what was bothering, but the just the being on the medications themselves was really the part that was bringing him down. He had very severe symptoms, so he had a lot of urgency, lots of nocturia, which means that he was getting up probably about 5 to 7 times per night to urinate. He also had something that's relatively unique in the fact that he had recurrent infections in his prostate. Infection can be a reason for us not to do the procedure, so that's probably not something that we should highlight too much, but he was having recurrent infections as an issue, and all of his symptoms resolved after we did the prostate artery embolization. He was able to come off his medications, and his quality of life significantly improved afterwards.
Had he ever had surgery before? Or any kind of surgery?
In the past.
None. And how long had he been taking the meds? Do you know? How long had he been?
Offhand, I remember. I want to say it was at least 5 years. It may have been longer.
Okay, I'll ask him, but that's good to know. And I know in the email where his name was, it mentioned that he was a former smoker. Mm-hmm. Could that have been a risk factor in this, in terms of lifestyle?
And I think he had a family history. Those are really the two biggest, but smoking is certainly a contributing factor to BPH.
And he had a family history. Is by the way, not in this case, I don't know, but is obesity an issue, a factor, possibly?
Obesity can be seen in patients in particular patients that have a sedentary lifestyle. Right. So patients that aren't very active, unfortunately, those patients do tend to be a bit more obese. So obesity in itself is not. Obesity in itself actually is. Obesity is a risk factor. I take that back. But sedentary life associated with that is also part of it.
So men who, as you get older, taking care of yourself, which you should do anyway, like exercise, weight control, and healthy diet is important for prostate health as well. Just to make
for sure. Yeah.
Fantastic.
Overall, definitely important. But even the healthiest men, if they have risk factors, family history, those sorts of things, they're still at high risk of developing it.
Gotcha. Did he have any other issues, other comorbidities like high blood pressure or heart disease or anything that you know of?
I'm trying to remember. He may have had some heart disease. I mean, some high blood pressure, but it was mild. He didn't have uncontrolled hypertension or anything like that.
So you're probably thinking his age and family history were the main contributors, I guess.
Yeah, I think so.
And he's doing great. And anything else that we should mention? I mean, I know we want to make men aware that this is a viable... Oh, by the way, in my research, I also found something that's relatively new called Resume. It's water vapor therapy for the prostate. Have you heard about this, or?
It's probably one of the minimally invasive treatments that's offered by surgery.
Yeah, it's called REZUM, and water vapor therapy. It was approved by the FDA supposedly about 5 years ago or something. And it's Resume is the name of the manufacturer or whatever that provides. I don't know. Was approved, but anyway, they're saying it uses steam. From water steam or something, I don't know. I just, it's like, well.
Yeah, that's not particularly familiar with, but it looks like it's one of the minimally invasive surgeries. Yeah. So this is another method of removing portions of the prostate.
And right there are others, but in terms of effectiveness, minimal side effects, and if you will. The PAE seems to be the most viable non-surgical or minimally invasive procedure that's growing, and it's being used more and more. Correct?
Yes.
And is that the message you want to put out there? I guess can you say what message you want the men to take away from this?
Edit message of non-surgical, minimally invasive procedure to treat symptoms of BPH.
Yeah, fantastic. And
we can say with fewer side effects also.
Right. And this is also a procedure. Is this procedure also that's for men? That's considered for men with prostate cancer? And maybe that's because you're I believe a interventional oncologist, correct? Or
yeah. Interventionology and oncology, those are two terms that we use in the field. It's not approved for treatment for prostate cancer. Okay. That's one thing that we look for in patients that come for the procedure is to see if they do have a history of prostate cancer. That's important for good communication with their urologist, because after we do the prostate artery embolization, if the patient were to have an MRI within a year or so after the treatment, it's going to be difficult to detect prostate cancer that could be developing, that would otherwise be there. It's going to be difficult to find it. There have been some studies that are looking at treating prostate cancer with PAE, but that's not something that we're supporting as of yet.
Okay, so that is one of the criteria. You cannot have had prostate cancer to undergo this treatment.
In general, it's not an exclusion, and if we have good communication, like I said, with the urologist, then we have treated patients that have prostate cancer. That's usually well under control.
Okay. And I think that's it. Unless did I leave anything out that's important to know about the PAE and related?
When you call Dr. Munoz, you're going to be pleasantly surprised. He's a very nice gentleman who is very happy with his outcome.
Does he speak good English?
His English is pretty good.
Okay.
It's pretty good. He definitely speaks better Spanish, but he can get by.
Well, I can speak Spanish, so I'll get by. I was just curious, just going in, make sure, but I'll hopefully speak Spanish. I mean English. Great, doctor. Your title is an interventional oncologist, or
so the prostate artery embolization. It's interventional radiologist.
Okay. And go ahead.
Work, but it's separate from prostate artery embolization.
So interventional radiologist, and with MCVI.
Yes.
Okay. Yeah, because sometimes I have overlap here. All right. Great. So go ahead.
has to do with more with MCI,
Right.
but the interventional radiology that I do is MCVI.
Okay, fantastic. And what we're going to do is hopefully next week or soon we'll speak with Dr. Muniz and put an article together, and I will send it to you. Make sure I got everything right regarding PAE and everything else, and then we'll hopefully publish soon thereafter.
Fantastic, sounds great.
So thank you for your time, and Carmen and myself will be in touch with you pretty soon here. Thanks
All right,
again.
thank you.
Oh, and send me whatever you have. Yeah, you're going to email me something, please, whenever you can. You have my email, right? Yeah.
Let me just double check that I have the right email address.